Hello. Hello. Can you hear me? Hello. 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 Can you hear me? Hello. Hello. Hi. Welcome to the third session of our dermatology series. So today we'll be looking at a few of the infections and infestations that are most commonly seen in dermatology clinics. So we can define skin infection as disease which is usually caused by an external organism, which can also include insects and mites. It does not necessarily have to be bacteria, fungi, or anything. It can also include mites and insects. And these organisms they lead to some inflammation in the skin, and this provokes our innate or acquired immune reaction. And as a part of that, it reacts like in various ways. In that case, we can develop acne or dermatitis, which can be perioral, seborrheic. There are like so many different skin conditions which occur following these kinds of inflammatory diseases. The skin eruptions can occur as an immune mediated reaction, example, erythema, or can sometimes occur after taking some drugs, which can be some drug reactions like morbilliform drug eruptions, which is usually seen secondary to taking some antibiotics. So these are a few examples and pictures, clinical pictures of a few infections that can be seen commonly. So one of the most common example for a bacterial infection is impetigo, which is contagious and it's a superficial skin infection, and it's most commonly caused by Staph aureus and Streptococcus pyogenes. Another common example of the viral would be the warts that we usually see regularly. Warts are usually benign conditions, and these are caused by HPV viruses. The other condition most commonly that occurs for fungal category is candidal inditrigo, which usually occurs in the skin folds where there is like more sweating and more moist. And this is usually caused by candida. Another ectoparasitic example is papillary urticaria, which is like the response of the body following any bites from any arthropods or mites or spiders or anything like that. So, a few cutaneous bacterial infections, the most common of them are cellulitis, impetigo, folliculitis, pharyngals, erysipelas, and leprosy. So these are a few pictures of all the infections, like some of the infections that I just mentioned. The first one is the one that's called carbuncle. Then we have erysipelas and leprosy. And coming to any of the viral infections, so usually viral infections are really common, but sometimes it can be a bit difficult to diagnose, especially in children when they present with atypical features. So, some of the common examples include eczema herpeticum, varicella, herpes zoster, measles, roseola infantum, erythema infectiosum, papillar purpuric glove and sock syndrome, papillar acrodermatitis of childhood, which is a reactive condition. These are the pictures of a few conditions that I just mentioned. The first one is eczema herpeticum. The second one is varicella, which is chicken pox. And the next one is the measles. Other fungal conditions include tinea pedis, tinea corporis, pityriasis versicolor, and candidal intertrichum. Fungal conditions are commonly mild, but if the patient or the person is immunocompromised, then it can lead to some severe conditions. We usually, the fungal infection of the skin is known as mycosis. This is the example of one of the fungal infection, tinea pedis, affecting the foot. Some of the cutaneous ectoparasitic infections, uh, like by ectoparasite we means any organism that is outside the surface of the host. This can include scabies, papilla urticaria, and pediculus capitis, which means the common head lice. This is an example of the scabies infection, which is one of the most common itchy condition that is usually seen, and it is characterized by burrows, which we'll come to later when discussing the case of scabies. So the diagnosis of any blistering dermatosis, it mainly depends on what site of the skin or where exactly in the epidermis it's affected. So, uh, there are like different anatomical levels for the skin as shown in the picture. So, it can be for the epidermis, it's stratum basale, stratum spinosum, granulosum, lucidum, and corneum. So, the skin cleavage levels can we can classify as subcorneal, which includes stratum corneum lucidum, intraepidermal, which includes the rest of the epidermal layers, and subepidermal, which means just beneath the stratum basale, which mainly includes the basement membrane. Coming to the example, if it's subcorneal, examples of the diseases that affects the subcorneal level includes bullous impetigo, and SSSS, which is the staphylococcal scalded skin syndrome. Intraepidermal bullae, the examples include pemphigus vulgaris, pemphigus foliaceus, varicella, and herpes simplex. Subepidermal bullae include bullous pemphigoid, dermatitis herpetiformis, and TEN, which is toxic epidermal necrolysis. So, coming to the first condition, it is staphylococcal scalded skin syndrome. So, this is usually caused by the release of exotoxins, mainly from Staphylococcus aureus. And most commonly, it affects children under the age of 5, but also individuals with immunocompromised history is at higher risk. And the most common symptoms are fever and widespread erythema of the skin, and usually it just get worsened very quickly, and within 24 to 48 hours they start forming small fluid filled blisters which then get ruptured again, and in that case the Nikolsky sign will be positive. And this rash easily spread to other areas of the body, and it's basically like the top layer of the skin just begins to peel off, and this leaves behind a moist erythematous area. One common thing that to note about this condition is that the mucous membranes are usually spared. The staphylococcal scalded skin syndrome is caused by the release of exfoliative exotoxins type A and type B, mainly from Staph aureus. And these toxins usually target desmoglein, which is a molecule within the desmosomes. And these desmosomes are mainly required for cell to cell adhesions. So, as a result of this toxins affecting the desmosomes, the bonds between these adjacent desmosomes are broken and the skin cells become unstuck. In SSS, the toxins diffuse from a focus of infection, and in the absence of a specific antitoxin antibody, they spread hematogenously to produce widespread effects. In children, the infectious focus is most commonly in the nasopharynx or in the conjunctiva. So, this shows the example of a normal skin, and when it's exposed to the exfoliative toxins, how it affects the desmosomes and it becomes unstuck. So, the diagnosis of the staphylococcal scalded skin syndrome is mainly by history and clinical findings. So, we can take a skin swab for bacterial culture and sensitivity. We are mainly looking for Staph aureus. So, these are taken from the sites of the infection. We can also send cultures, which include blood cultures, urine cultures, and stool samples. And we can also take skin biopsy for histopathology to differentiate this condition from other blistering dermatosis. And the histopathology usually shows, just as mentioned before, subcorneal cleavage and acantholysis. Coming to the treatment of the condition, so the first thing is general measures, and most of the conditions are usually severe, and all of them require admission to the hospital. And in very severe cases, they might end up in a burns unit or an ICU. So we have to give appropriate skin and wound care, and the another main thing is the IV antibiotics. And we have to be aware that we have to prevent dehydration in these patients because of the skin peeling and exposure of the surface. There is a large amount of fluid loss. And in that case, we need to supplement them with the adequate IV fluids. And we also have to look out for any electrolyte abnormalities and correct accordingly. And when it comes to skin care, we have to minimize the damage to the skin because even like a small trauma can cause severe blistering, discoloration, and pain. So we try our best to avoid the use of adhesives and tourniquets, any compression devices, any tapes, all of them we do not use in this case. And when the patient is having a bath, we only prefer to use like a very gentle cleanser, and the skin should be just patted dry instead of using a bath towel to dry it. And we can also try and apply petroleum jelly every 2 hours for the skin. And we have to limit the use of wound dressings because this can, in a way, aggravate more discoloration and pain. But we can still use non adherent dressings such as petroleum jelly embedded gauze in order to protect large erosions. And we also have to give adequate analgesics such as paracetamol or further and like analgesics as required if the pain is too much. When it comes to the IV antibiotic regimen for children, we use a penicillinase resistant antistaphylococcal antibiotic like flucloxacillin. The Staph aureus is the most common cause of SSS. The alternatives can be nafacillin or oxacillin, cephalosporins, and clindamycins. Vancomycin is used to treat infection with methicillin resistance. If the condition is left untreated or the treatment is unsuccessful, this can lead to very severe sepsis and cellulitis and pneumonia, and even death can occur in case of severe infections. Another of the condition is bulla sympatico, which is also a bacterial condition. So this is also caused by the toxin producing strains of Staph aureus. In this case, it is mainly characterized by the development of bullae that are like thin roofed and they easily rupture and forms like a collarette of scale around it. In this case, the Nikolsky sign is negative, whereas in SSS, the Nikolsky sign was positive. These lesions usually develop on the trunk, buttocks, face, extremities, perineal regions, and they can usually spread due to auto-inoculation, that is from one lesion to the other. Bullous impetigo, this can also cause systemic symptoms like fever, malaise, and lymphadenopathy. The another condition which is really severe, we only have like few emergencies in dermatology, and this is one of them, which is Steven Johnson syndrome or TEN, toxic epidermonecrolysis. This is acutely serious and potentially fatal condition caused by medications usually. And the onset usually happens within like 1 month of starting a new medication. And in case of children, this is more likely triggered by some infection. So they usually have like prodromal symptoms like fever, sore throat, runny nose, cough, and generalized myalgia. And then there is like an abrupt onset of erythematous blistering rash on the trunk, and this just extends all over the body, to the limbs, to the face, and this results in large areas of skin being denuded. And in this case, even the mucosa is involved, which is really severely, and the Nikolsky sign is positive. In these cases, they need like immediate admission, mainly to the intensive care units, and appropriate management. So, coming to one of the cases, so a 3-year-old boy presents with rashes around his mouth and hands and feet, and they're grayish vesicles, and some have crusted over. He also has some vesicles and ulcers in and around the mouth, palate, and pharynx. He attends nursery where other children have similar rash. He doesn't have any other previous skin history. So in this case, we just have to think of the most common differential diagnosis. Since it's a boy with rashes around his mouth, hands, and feet, one of the differential diagnoses would be HFMD, which is hand, foot, mouth disease. And the one we can think of varicella, or it can be herpangina or eczema herpeticum. So in this case, it is more than likely to be HFMD. So HFMD is hand, foot, and mouth disease, which is usually caused by an enteroviral infection, mainly Coxsackie virus A16. The given picture is an example of how the lesions would look in a kid with HFMD. So in this case, they have like blisters all over around their hands, feet, and inside, even inside the mouth and around the mouth. Usually, it's seen in children with an age of 10, and high proportion of infection occurring in those around the age of 5. Due to its highly infectious nature, it is usually most of the members of the family or the school, everyone would be affected. And if you, when you're taking the history, you can always ask about contact history and similar history in the family or the nursery or the school. This is the case of herpangina, which is also another enteroviral infection. It is usually seen in children up to 10 years of age, but it can also affect all the ages, even young adults. Initially, it presents like with fever, sore throat, pain on swallowing, and this is usually followed by development of intraoral vesicles on the soft palate, tonsils, uvula, and back of the throat. Another one of our DTs was varicella, which is chickenpox, which is highly contagious viral infection. And as you all know, it's caused by varicella zoster virus. This is characterized by the development of itchy red papules on the trunk and face, and this later progress to vesicles, which spread to other parts of the body. In worst cases, intraoral blisters can also develop. The infections can be associated with systemic symptoms like fever, malaise, headache, vomiting, diarrhea, runny nose, etc. This is a case of eczema herpeticum, which is this is a most likely a disseminated viral infection, and this is caused by herpes simplex virus type 1 or type 2. This is characterized by fever and development of clusters of itchy blisters or punched out erosions. So in this case, these are like seen as clusters, where in the previous cases they are more widely distributed. This is most commonly seen as a complication in children with atopic dermatitis. So hand foot mouth disease was our original case. So when it comes to diagnosing HFMD, it's mostly clinical and based on the history and examination. So it's based on the typical appearance of the lesion and the location of the lesion, which is around the mouth, hands, and feet. If we need an etiological confirmation, we can take throat or stool or vesicular fluid samples for PCR, but we usually do not use it because it's mostly a history based and clinical based diagnosis. Blood tests are done only in children who are ill with this disease, and in that case, there might be raised white cells, atypical lymphocytes, and raised CRP. HFMD is more common during the warmer months of the year, and so the prevalence of the infection peaks in late summer and early autumn. Sometimes we get atypical presentation of the HFMD, which is due to Coxsackie virus A6, and this results in a more widespread rash, large blisters, and the atypical HFMD, in which there is like large blisters and widespread rashes. Another case is eczema coxsackium. This has been described as atypical HFMD. This is caused by Coxsackie virus A6, as mentioned before. So these lesions, they are usually localized to the sites affected by atopic dermatitis, but they can also be present on the unaffected skin or the skin that has been previously affected by dermatitis. This results in a more widespread rash with vesicular bullous lesions that can ulcerate and scab. Oral ulcers can be present but are less common than in typical presentations of HFMD. One of the main differentials when it comes to eczema coxsackium is eczema herpeticum. It is a bit difficult to tell both of them apart, but we usually treat it empirically for HSV. In contrast to eczema herpeticum, eczema coxsackium self-resolves and does not usually require hospitalization. When it comes to the treatment of HFMD, we do not have any specific treatment. It's mainly conservative management. But there are a few things that we just have to be aware of. So the bulla, they should not be ruptured. Instead, we just have to keep them clean, and we can apply non-adherent dressings over the erosions. And we just have to make sure the child has adequate fluid intake so that he is not dehydrated. Especially if the child is having blisters inside his mouth, then his diet and his oral intake would be affected. So, if the oral intake is severely affected, in that case, he might need admission to the hospitals for IV fluids. And we can give him analgesics, which can be topical or oral, and can give antiseptic mouthwashes, which might help in some relief of pain for the oral ulcers. In most of the cases, this is just a mild illness which usually settles on its own. So we do not usually keep children once they are well enough to attend. We can send them to the schools. And the blisters are usually infective until they have dried up. So which is within a few days. So after they have dried up, it's not infective. And in that case, if the children are well enough to go home, to go to schools, we can usually send them to school. Coming to the second case, there is a 17-year-old male who presented with 2-week history of an itchy rash, which is worse at night. On examination, he has burrows on his hands and feet, including on the sides of his fingers and toes, the web spaces between the digits, the wrist, and his instep. He also has a widespread eczematous eruption on his torso and limbs, and we can also see linear excoriations. So, one of the main differential diagnosis in this case would be scabies, because he's having this is the clinical presentation with severe excoriations and really itchy lesions. So other DDs could be dermatitis, folliculitis, papular urticaria, and psoriasis. So coming to scabies, it is a really contagious disease which is usually caused by the ectoparasitic mite known as Sarcoptes scabi var hominis. This is usually transmitted by close bodily contact. And the most common presentation would be extremely pruritic rash that is worse at night. And there will be erythematous papules affecting hands, wrist, axilla, thighs, buttocks, waist, and soles of the feet, in between the fingers. In some cases, the face, scalp, and neck, usually spared, but it can be affected in cases of crusted scabies, which we'll come to later. If the patient is having a darker skin tone, this may present as like granulomatous nodules. And you can, in this case also, you can ask about similar history in the family or someone like in school or anything, because since this is highly contagious, um, even when we treat scabies, we usually treat the family as a whole. So this is the life cycle of the mite that causes scabies, the Sarcoptes scabi life cycle. So when it comes to diagnosis of the scabies, so we usually suspect scabies when a patient presents with severely itchy rash, uh, which is mainly affecting his extremities and the trunk. So in that case, we have to do a proper clinical examination and take history of contact or similar history in the family. So the pathognomonic features of scabies on examination are burrows. They're like thread-like tracks which measures around 5 to 10 millimeter, and they are usually seen in between the web spaces, soles and palms, fingers and toes, inner wrist and elbows, umbilicus, and around the belt line. There can be nodules around 3 to 15 millimeter that can develop in the axilla, upper thighs, gluteal folds, and sometimes around the areola in the woman or penis and scrotum in men. Infestation in infants, usually the burrows are present on the palms of the hands and soles of the feet. They can sometimes also be seen on the trunk, head, and neck. So when someone comes with suspicion of scabies, burrows are the pathognomonic feature that we should be looking out for. So we can use a dermoscope uh, for further examination of the lesion. So each burrow is like a few millimeters long and it's really tortuous with a dark dot at one end adjacent to the burrowing mite, and often it is surrounded by a mild erythema. So when we use a dermoscope, one of the signs that we look out for is the delta sign, which represents the anterior body of the adult female mite. So the dermoscope helps us to identify the skin burrows, the mite with the delta sign, and the X, and we can also use dermoscope to assist us in taking some skin scrapings. So when we take skin scrapings, we usually send it for microscopy. And this is a microscopic picture of what's seen for a scabies. So usually these scrapings are placed on a microscope slide with a few drops of 10% KOH, and this is covered with a cover slip and examined under the microscope. And the presence of the mite, egg, or eggshells confirms the diagnosis. When it comes to the treatment, we usually take some general measures. So, all the clothes, the bed sheets, the towels that have been used, they should be laundered, and we prefer to wash it in high temperature and dry it outside in the sunlight. The outer garments, duvet, and blankets, they should be aired for 72 hours. We should clip the nails and clean any of the subungual debris. For the topical treatment, we can have 5% permethrin cream or lotion, which is usually applied from jawline downwards, including under the nails and between the toes. So we have to specifically mention it has to be applied from jawline downwards, including under the nails and between the toes. And it is usually left overnight for 8 to 12 hours. In case of immunosuppressed individuals or infants, we should also treat face and scalp. Reapplication is usually suggested if the hands are washed during the treatment period. And this treatment should be carried out on day 0 and we do a repeat dose on day 7. The oral treatment includes ivermectin, and the dose is 200 micrograms per kilogram of the body weight. And this is usually taken in conjunction with the application of the topical therapy in severe cases. Uh, the scabies can sometimes develop complications. So, one of them is secondary bacterial infection, which usually occurs following scratching of the lesions. And as a result, the ability to fight the bacteria decreases, and this can cause bacterial infection. Staphylococcal and streptococcal infection, they usually result in crusted plaques and pustules. Streptococcal cellulitis results in painful swelling and redness and fever. Systemic sepsis with staphylococci and streptococci is potentially very serious. Sometimes the streptococcal infection can also lead to post-streptococcal glomerulonephritis and acute rheumatic fevers. Another complication, as mentioned, is crusted scabies. This is a highly contagious variant of scabies, and in this, the individual develops like really thick crust of skin, which is infested by thousands of mites. And these mites are present in such huge numbers because of the altered host response to their presence. So this usually happens when there is some sensory loss from some neurological disorders, and the person is not able to perceive the itching, and also in individuals who are immunosuppressed. So in these cases, or when patients are unable to scratch properly, so in these cases, all this can lead to cluster scabies, which is like really contagious variant. So in these circumstances, when the host does not itch or cannot scratch, these burrows are not destroyed, and as a result, the mite population rapidly multiplies. So, so these are a few like so we just discussed one of the bacterial condition, one viral, and one ectoparasite conditions. So that's the end of the lecture. If you can scan this QR code or go to the website, you can provide the feedback and you will get the certificate via the link. Thank you.